Hello, everybody. Today we will talk about mood disorders. It's one of the most important topics in your USMLE exam. As usual, we will have an overview of the topics that we will talk about today, and they belong into the mood disorders presentation. We will start by giving a definition of mood disorders and also make a classification. And then we will talk about mood episodes. We're going to talk about a depressive mood episode, manic episode, mixed or hypomanic. Then we will talk about depressive episodes. We will talk about major depressive disorder. We all know it's a very important topic, not only for the USMLE exam, but in general in life. We will talk about all the important details when it comes to a major depression or major depressive disorder. We will give a definition. We will talk about symptoms, diagnosis. We will talk about how you diagnose it, and how you treat it. Then we will talk about depression in the elderly. It's also a very important topic nowadays. And then we will talk about postpartum mood disorders, such as postpartum blues, postpartum depression, and postpartum psychosis. After depression, we will talk about bipolar disorders. We will define what the bipolar disorder is, and we will talk about, again, the epidemiology of the disease. We will talk about how we diagnose it, and obviously how you treat it. There is a specific category, let's say, of mood disorders, and those are the substance or let's say medical induced mood disorders, and those we will talk about in the end. As usual, we will have some questions, either straightforward questions or clinical vignettes for you guys to check your knowledge on the specific topic of mood disorders. So let's start with mood disorders, and let's start with definition. So what is a mood disorder? So mood disorders are defined by the presence of mood episodes, like we see here on the slide, the presence of mood episodes. And the types of mood disorders are basically three. We have depressive mood disorder, and here we can talk about major depression or major or depressive disorder or dysthymia. We will talk about those terms later. We have bipolar disorder, which is, let's say, subdivided into bipolar 1, bipolar 2, or cyclothymia. And last but not least, we have mood disorders, secondary to the famous GMC, the general medical conditions, or mood disorders that are caused by substance abuse and or medication. So, before we talk about the mood disorders, we talk about depression and bipolar disorder and so on and so forth. We must actually define or talk about the mood episodes, because this is those episodes are the ones that actually make up those disorders. So, mood episodes represent, like we can see here on the slide, a combination of symptoms comprising a predominant mood state. So we talk about a depressive mood episode, a manic mood episode. It can be mixed, so combining characteristics from both categories. And it can be hypomanic. And obviously we will talk about those terms in detail very shortly. So we start with the major depressive episode. You can say depressive episode, you can also say major depressive episode. It doesn't really matter. What matters is how to define it. So depressive mood or anhedonia, remember we've seen this word before in the psychotic disorders presentation. Remember, it's a Greek word from anhedonia, meaning the inability to feel pleasure, to feel interest when you do something. So again, going back to the definition of the major depressive or just depressive episode, we're talking about depressed mood or anhedonia, and at least 4 of the following symptoms or signs present for a 2-week period. Here, things are simple. There is a mnemonic for you guys. I personally like this. It's a sigma, let's say CAPS, So we just remember, the cap that we wear at a baseball game or whatever, when it's hot outside and you don't want your head to get burned. So you remember caps, and you also remember the Greek letter sigma, as we have here, sigma. Some people also write it like this way or like that way. It doesn't really matter how you write it. It's a Greek letter sigma from the Greek alphabet. So if you remember sigma plus caps, then you get the acronym for the mnemonic, the sigma caps. So sigma. So S stands for sleep. People usually have hypersomnia or insomnia. I stands for interest. So like we talked about on the definition, there is anhedonia. So there's usually lack of interest. Lack of, let's say, pleasure and interest into doing things. G is guilt. People are feeling worthless or guilty. M stands for mood. Obviously, mood is depressed, since we're talking about the major depressive episode. A stands for appetite. So the appetite can be either increased or decreased, aka the weight can either increase or decrease. It depends. There's no golden rule when it comes to the weight and the appetite, but for sure it's not normal. C stands for concentration, and concentration is decreased. E stands for energy. Energy is decreased. People are fatigued. They are tired. P for psychomotor agitation or retardation. I think those terms speak for themselves. And S again for suicidal thoughts. So this is a very nice mnemonic for you people out there, just to remember what are the main symptoms or signs, you can say, for the major depressive episode. Now, we need at least four of those symptoms in a 2-week period, along with the anhedonia or depressed mood. So some of them, as you can see, are already included in the definition. Now, from the major depressive episode, we're actually moving to the manic episode. So we're actually going to the other side of the spectrum of, let's say, the mood spectrum or the mood episode spectrum. So what is a manic episode? So a manic episode is basically a period of abnormally and persistently elevated, or let's say irritable mood, that lasts at least 1 week or less if the patient is hospitalized. So it's a little different, it's different if the patient is, let's say, at home or is at work, or in general he's living their life, compared to a hospitalized patient. So we have symptoms here, obviously, like we had in depressive episode. Another mnemonic, for you guys. Now it's dig fast. Another good mnemonic makes our life easier. So we had the sigma caps for the major depressive episode. Now we have the dig fast for the manic episode. So in this case, we need three symptoms to confirm the diagnosis, or 4 if the mood is only irritable. So D stands for distractibility. I stands for insomnia. G for grandiosity. So when people have an inflated self-esteem. F for flight of ideas or racing thoughts. A for, let's say, agitation and an increased level of activity. S for sexual indiscretion, for spending, for speeding, for substance abuse. So S basically can stand for all those bad things that basically people do in the movies, let's say, if you want to make a joke here. Or inappropriate speech. So there's a lot of bad words included. People are spending money, and they're gambling, and they're maybe doing drugs, and they're really talkative. So T stands for talkativeness. So people are actually talking a lot, and the speech is actually pressured. So pressured speech. So remember the dig fast mnemonic. Dig fast mnemonic. It's a very nice mnemonic here to remember the symptoms or signs of the manic episode. If you guys remember now, in the introduction, we talked about depressive episode, we talked about manic episode, but there's also a mixed type of mood episodes. This is the mixed mood episode. And what happens in this case is that we have criteria being met for both manic and major depressive episode every day for 1 week. And this is what the mixed mood episode is. Now, remember here that we have a fourth type of mood episode, and this is the hypomanic. So the hypomanic, like we can read here on this slide, is a period of abnormally and persistently elevated or irritable mood lasting at least 4 days. So now we're going, at the mix we saw there's a week time limit, let's say. Here the minimum is at least 4 days. So what happens? We have the dig fast again. The criteria for the dig fast are met, and there's also symptoms. There are symptoms that follow the dig fast mnemonic, but there are no symptoms due to the GMC, the general medical condition, or due to some substance abuse. Now, when a person is undergoing a hypomanic episode, his functioning obviously changes, and is recognizable by others, of course. However, most of the time, that's why we also have the hypo prefix, which is not manic 100%, but hypo, so less than manic, let's say. So the hypomanic episode doesn't really require any hospitalization. Or it doesn't really cause a big social impairment. Obviously, again, there's no golden rule, and you guys will see in your medical practice in the future that there are no golden rules with this stuff, but this is a general rule just to, let's say, distinguish it from the classic picture of a manic episode. And a very important point here is that in the hypomanic episode, there are no psychotic features. So remember, we did in the previous presentation, one of the previous presentations was the psychotic disorders. We talked about the psychotic features, positive and negative symptoms of schizophrenia, so on and so forth. There are no psychotic features in the hypomanic episode. Now, moving forward, so we talked about the mood episodes. So from now on, since the presentation is about mood disorders, we will actually dig in the mood disorders. But what are the symptoms, or what is the presentation of the mood disorders? It's those episodes we talked before. So in major depressive disorder that we have here, for example, the MDD, as we usually abbreviate it in everyday medical practice, the MDD, major depressive disorder, or let's say DD, double D, depressive disorder, it doesn't really matter. This disorder is defined by the presence of one or more major depressive episodes. So the mnemonic sigma caps that we used before. Now, as we usually do, we always take a look at the epidemiology of every disease or disorder, and here we see that the major depressive disorder is present in mostly in females. Actually, is 2 times more compared to males. If we want to talk percentages, literature gives us a 3% prevalence in men, and 6 to 7, so double, like we said, in women. And it usually arises around 25 to 30 years old. Now, what causes a major depressive disorder? So there are many theories. We have here some let's say important points for the cause of major depressive disorder. So there might be a dysfunction at the level of the release of the neurotransmitter from the synapse. We're talking about decreased activity of norepinephrine, dopamine, or serotonin. It can be a genetic etiology. So in monozygotic twins, there's 65 to 75% people. There's a let's say concordance for the DD, and in dizygotic twins, 15 to 20%. And there's also psychodynamic factors such as the low self-esteem that a lot of people actually have in their everyday life. So as we said about schizophrenia and the other psychotic disorders, the etiology of those disorders, both for psychotic disorders and mood disorders, is multifactorial. So there's no single etiology. What are the risk factors for MDD? Female sex, so we said before, is much more common in women. The age is very important. The 25 to 50, we said 25 to 30, doesn't really matter. It's over 25, let's say. Some people say 20 to 50, doesn't really matter. So it's around that age range from 20 to 25 to 50, or 30 to 50. Of course, there are other reasons like the alcohol abuse and the sociopathy and problems in the family, recent deaths in the family. Let's say when people are isolated, they live alone and they don't have a relationship, or they are, let's say, molested as a child. They have been molested as a child, so bad experiences from early childhood. Other causes might be stressors, everyday stressors like illnesses, financial problems, stress in general, legal issues that you may have in your everyday life. So all these are risk factors for the MDD. Now, how do we diagnose? The major depressive disorder? So we need a history of one or more major depressive episodes, and we need the absence of manic, mixed, and hypomanic episodes. This is a very important point. We'll take a pause here and we will repeat this. This is very important, and it's also high yield information for the USMLE. It's very important to distinguish between the MDD, the manic, the mixed, and the hypomanic. So I will repeat this one more time. In order to diagnose positively an MDD, we need history of one or more major depressive episodes, and at the same time the absence of manic, mixed, or hypomanic episodes. Now, moving forward, this slide also talks about subtypes of the major depressive disorder. It's very good to have this also in our heads, just to remember that there's no, let's say, golden major depressive episode and that's it, only one version. There are many versions, there are many subtypes. So we can see here we have MDD with psychotic features, some hallucinations or delusions. We can have a chronic MDD which lasts 2 years, more than 2 years. We can have MDD with melancholy. Some people say melancholy, some people say melancholy. Again, it's another Greek term which means sadness. So the quality of mood is depressed, like we can see here, and it usually happens in the morning. So you wake up and you're feeling sad and hopeless, and you wake up early in the morning. You lose weight, and you have let's say feelings, or let's say depressive feelings. Let's put it this way. We can have a major depressive disorder with atypical features. We can see here that they mention increased sleep or weight gain. So you put a lot of weight. You can have a major depressive disorder postpartum. So that happens actually 1 month after birth, and there's a higher recurrence risk, and sometimes it occurs with psychotic features. And last but not least, we can have a seasonal pattern MDD. So it happens at the same time every year, and usually happens in the winter. So those are the main subtypes of the major depressive disorder. Those are the ones that you guys need to know for the USMLE exam. There are other types. There are other subtypes that the list is endless, basically. Mood disorders and depression are huge chapters in psychiatry. They're still under investigation. But speaking about the USMLE and what you guys need to know for the exam and for the high yield questions and answers that we will actually go over later, I think those subtypes are more than enough to cover you for the final exam. Now, my favorite part for every disorder that we talk about here is treatment, because it's very nice to diagnose it, or actually define it, know what it is, see the symptoms, diagnose it. But a very important part, and to me as a medical doctor, the most important thing is how you treat it, because at the end of the day, you actually need to help the patient. So it's very good for you to know what's going on, what the symptoms are, and also very, very important to diagnose it. But the point is to help the individual. So how you treat it. So how you treat depression. You give antidepressants. Everybody knows about the antidepressants. And you can do also psychotherapy. You can go to a psychologist, a psychiatrist. You can have a group therapy, cognitive therapy. You can do the ECT. We'll talk about that soon, the electroconvulsive therapy. We can have a phototherapy also, or the transcranial magnetic stimulation. Now, let's go into more detail into the treatment of depression. So the first thing we actually talk about here is the antidepressants. Very important, high yield. You name it. Very important part of basically all the exams in medicine, not only USMLE. Very famous drugs, and the SSRIs. We have here the SSRIs, the selective serotonin reuptake inhibitors. The name speaks for itself, right? So they block the reuptake of serotonin at the synapse, and we have several drugs here: the paroxetine, citalopram, sertraline. Those are fluoxetine. Those are very famous drugs, and you guys should know these names too. They're very important. They have some side effects. People have reported sexual side effects. For example, women cannot have an orgasm, impotence in men. There might be some GI distress, like we can see here, some tremors, maybe vomiting or diarrhea, insomnia. But the main thing with the SSRIs is the sexual problems, the sexual side effects. If we take a very quick look at the pathophys, let's say, or the mechanism of the drug, what the drug does is to inhibit the P450 enzymes, so increases the levels of drugs metabolized by P450 system, and of course we must mention here, since we basically let's say inhibit or block the reuptake of serotonin, so we have accumulation of serotonin at the synaptic level. We observe the serotonin syndrome with the monoamine oxidase inhibitors, so which is basically another type of antidepressant. So if you combine the SSRIs with the MAOIs, which will be covered very soon in this video, if we combine those types of antidepressants, then we get serotonin syndrome, which is basically let's say famous, quote unquote, in the medical world. Some doctors say it's not very common. It's common on the USMLE exam though, so you guys should know that we are referring to nausea and diarrhea and the palpitations and the hyperthermia, chills. Your consciousness is changed, and also you have a neuromuscular irritability, as you can actually read here. And another point we should make here is that we should avoid paroxetine. Paroxetine, we went over it in the beginning. Another very famous SSRI, paroxetine. We should avoid this in pregnancy because it causes pulmonary hypertension in the fetus. So obviously we don't want to use that. And except for the SSRIs, we also have the SNRIs. This is serotonin and norepinephrine reuptake inhibitors. Mechanism is similar. We have duloxetine and venlafaxine. Those are the two most commonly used drugs, and those are the ones that you actually need to know for the exam. Venlafaxine and duloxetine, and a main side effect is that venlafaxine causes diastolic hypertension. Diastolic hypertension, remember that, not systolic, diastolic hypertension. So we talked about the SSRIs, we talked about the SNRIs. Now we will talk about the tricyclic antidepressants, TCAs as we say, and the MAOI, the monoamine oxidase inhibitors. So the TCAs, inhibit the reuptake of norepinephrine and serotonin, so they're similar to the SNRIs in this aspect. All those are the tryptylines. So nortriptyline, amitriptyline, there's a desipramine also, imipramine, and so on and so forth. Side effects. Important point for the USMLE exam, high yield topic. Side effects of TCAs, anticholinergic side effects. Again, we talked about those before in the psychotic disorders presentation. We talked about dry mouth and constipation and urinary retention, blurry vision, alpha-1 adrenergic side effects, so orthostatic hypotension, antihistamine side effects, for example, sedation and weight gain. And if you OD in TCAs, obviously you die due to conduction arrhythmias. So you have a long QRS, you have a slow AV node conduction, and so on and so forth. So if we look at the ECG, this is a very bad picture, but you guys, I'm sure you can find a better one online. If this is a normal ECG, let's say, obviously this actually would be the pathological one, because the way I drew the QRS is actually prolonged. So in this case, we are actually to the point. But a normal one obviously would be a lot thinner, but you guys get the point. So the patient will die from a conduction arrhythmia. Now, the last resort, let's say, of the pharmacotherapy for major depression is the monoamine oxidase inhibitors. They block the monoamine oxidase A and B, and that leads to increased norepinephrine and serotonin. So the result is the same as the previous drugs that we talked about. Phenelzine, selegiline, those are the patch. You use a patch with the selegiline. Those are the drugs. Side effects. This is another high yield topic, and you guys will see that question going around in the several forums and tests. When you combine the MAOIs with tyramine containing foods, for example, cheese, wine, cheese and wine mainly, you get hypertensive crisis. You get palpitations and photophobia. You get the alpha-1 adrenergic hypertension we talked about before, and less antihistamine and anticholinergic side effects. Now, we can use the atypical antidepressants. We have the mirtazapine, the trazodone, and the bupropion. You guys can actually see them here. They block the serotonin uptake, and they are acting as postsynaptic receptor antagonists. The mirtazapine is reported to cause some sedation or weight gain. Okay, not very important. Trazodone might cause priapism, and the bupropion might decrease a seizure threshold. So patients that have epilepsy and eating disorders, meaning they don't eat enough, so low glucose levels, so more prone to get a seizure. So we don't usually use the bupropion on these patients. Now, that was pharmacology. That was a very important topic. We will actually cover some of those drugs into the question Q&A portion of this presentation. However, drugs is not the only choice. There's also psychotherapy, and obviously you guys are familiar with this from movies and films and videos on YouTube and everywhere. It's psychotherapy, and we do the so-called psychodynamic therapies. We assume that the one's present outlook is shaped in the past. That's what the psychologist assumes, or that's what the psychologist believes in. And we're actually paying attention to some psychological forces, unconscious psychological forces, paying attention to the early development of the individual. So we go back to the early development from the baby years, childhood, so on and so forth. And we try to make the person feel better. Let's say those very simple words, but you guys get the gist of what I'm trying to say here. So we go back and we try to make it better by starting from the beginning. So we can also analyze dreams and associate them with the everyday life, patient's everyday life. Now we have some types here of psychodynamic therapies. We have psychoanalysis. Psychoanalysis is when you hear or when you see the term psychoanalysis or the explorative psychotherapy, those terms are the same. You guys should actually think of a couch. The famous Freud couch that he has in all the pictures you have seen online. The couch with the guy who sits and lies in the back and relaxes, and Freud, or this nice guy with the beard, not like mine, but with a white beard, an older guy, is sitting with his pen, and he's taking notes, and the guy is venting, and he's talking about his life, and he starts from childhood, right? So I'm not going to continue. You guys get the picture. So people do this almost every day. Here we have 4 to 5 times a week. People can do this every day, actually, for 3 to 5 years. And these patients are actually at the healthy side of the spectrum, the healthy end of the spectrum. So they're not like, let's say, the terminal or very important or very severe cases of depression. Now, then there is a supportive psychotherapy. Supportive psychotherapy is basically done more to reduce anxiety, and again, allows the person to vent and to create defense mechanisms and to confront several problems of everyday life, and to make them stronger, feel stronger, get a better or a stronger self-esteem. We have brief psychotherapy. This basically, well, the name speaks for itself. Brief psychotherapy, meaning that you actually do this for a short period of time to solve a specific problem. This is a specific problem, or a crisis that one might have. And there is interpersonal psychotherapy. Interpersonal, so we talked about the explorative, we talked about the supportive, short-term or brief, and then the last one we have here is interpersonal psychotherapy. Again, short-term treatment, paying attention, let's say, to personal social roles and relationships to help deal with problems in current functioning. So to make this simpler, interpersonal, so between people, solving problems of the individual that he's having with other people, and how basically we can, let's say, help or assist his role inside in the society. Not very important as far as USMLE is concerned, but it's good to know and have it in mind. You never know what's going to show up on the exam. Then we move to cognitive therapy. Cognitive therapy, the principle for cognitive therapy is that thoughts influence our moods and feelings, right? So what I'm thinking is actually influencing my mood and the way I feel about stuff and people. What the psychologist is trying to do here is that he's trying to, let's say, help the patient become aware of automatic thoughts, and correct any assumptions with more balanced views, right? So we understand, and we should make a point here, that this assumes a very good level of functioning from the side of the patient, right? Because you don't expect a patient who is at a very severe, let's say, depressed level or state, aka not a good functioning, to be able to respond to this type of therapy. So like we say here, a high level of functioning is needed. And we have group therapy, another term you guys have seen in movies and TV sitcoms and series and everything. People are gathering together, they're talking about their problems, there's a self-understanding there, acceptance, and people are improving their social skills with this type of therapy. Now, we're still not done with the therapy. Before, we talked about electroconvulsive therapy, or we just mentioned the term, the ECT. ECT stands for electroconvulsive therapy. So this sounds scary, but it's not actually. Well, not to me, who is actually giving the therapy, but obviously to the person who is undergoing the therapy. Obviously, this sounds very, very, very scary, but actually it's very helpful. It's very helpful. I had actually the chance to observe a lot of those ECTs while I was in medical school, in the last year of medical school, in my psychiatry rotation. And this actually, it's a very interesting topic and a very interesting procedure. So what happens is we basically induce a grand mal seizure. Grand mal seizure, I'm not going to get into details. It's a type of generalized seizure. We will talk about this stuff in neurology, in the neurology chapter. So let's say we induce a seizure using an electrical pulse through the brain under general anesthesia. So the person is anesthetized, and then we basically create the electrical pulse through the brain. It's safe, and it's highly effective, like I told you before. It requires 6 to 12 treatments. The problem here is since we induce a seizure, well, there might be post-ictal confusion. There might be arrhythmias. There might be headaches after the tests or the therapy or the shot. Let's say the shot. Let's speak slang here. Let's say the shot, the electrical shock that you give to the patient. Excuse me. And there might be anterograde amnesia. So people that had stroke before or myocardial infarction, people with intracranial tumors, people with ICP, stands for intracranial hypertension, you don't really want to do the ECT because you're basically messing up with their brain. Their brain is already, so I'm trying to make it simple for you guys. You don't want to mess up with the brain, which is already, let's say, in trouble. Let's put it this way. And those are cases that are very severe, very important, and so you don't want to do the ECT there. Now, we have phototherapy. Phototherapy is basically, photo is it means light, and you basically use light for people that have the seasonal pattern of depression. So you try to point light at them, or let's say place them in a more bright environment. And there's also the transcranial magnetic stimulation, the TMS, another very important, very interesting actually type of treatment for depression. What happens is with the transcranial magnetic stimulation, you have a probe. The probe looks like this, like my hand, and is placed on the side of the head like this. So it's basically stimulating nerve cells in the brain to improve symptoms of depression. And it's not the first choice. Let's say it's the last choice. So if the other types of treatment have not helped, you want to do that. Again, there's a lot of, it's under investigation, meaning there's a lot of questions about it. People are not sure. People, I mean, doctors. But the principle for you guys, the important thing to know is that you have a probe. You put the probe on the side of the head like this. It's like tilted, like a concave probe, and you put it like this, and you're basically transmitting electrical waves, and stimulating the nerve cells to treat the symptoms of depression. Now, obviously, differential diagnosis, very important part. It can be dementia. We have a mood disorder due to the GMC or substances, or it can be anxiety. Now, before we, so we're approaching the end of the depression, let's say, spectrum, the depressive spectrum. We must talk about dysthymia. So dysthymia is very similar to depression or the major depressive disorder. Let's say the correct form. People usually say depression and they mean the major depression or major depressive disorder. But dysthymia is, let's say, a depressed mood. It's a persistent depressive disorder, one might say, and it's a long-term form of depression, to make it even simpler. So at least 2 years of continuous depression. So the person is depressed, and the person has also at least 2 of the following symptoms. So either insomnia, hypersomnia, or low energy fatigue, poor appetite, low self-esteem, and he cannot concentrate, he cannot make decisions. So those are as you guys can see, very similar to the sigma caps symptom mnemonic that we did before. In the dysthymia, there's no evidence of a manic episode, no cyclothymia, and no mood episodes, past mood episodes. and obviously there's no GMC or any substance causing it. So we understand that dysthymia, since it lasts for so long, it causes let's say, discomfort in the everyday life. Makes everything hard. Social interactions are harder. Working, occupation is harder. There is distress at every move. So it's not very pleasant. It's not very pleasant. We make a note here of about depression in the elderly, because it accounts for 50% of acute psychiatric admissions in the elderly. 50% is like half, so it's, you guys can see it's majorly important, and affects about 15% of the residents over 65 years old. So community residents over 65 years old. So there's a high suicide risk due to increased lethality and decreased communication of suicide attempt due to social isolation. And let's say peaks around 80 to 90 years old in men, and 50 to 65 years old in women. So it usually shown earlier in women. And sometimes, like we can read here, it's presented with somatic complaints. So people have problems with sleeping. They're gaining or losing weight. They have energy problems, so they're tired, or they're tired basically. And let's say here that there might be anxiety symptoms rather than a classic depression. So again, major depressive disorder in elderly. It's not really a major depressive disorder. It's depression with anxiety features, let's say. So it's not major depression. So you couldn't say that. Now, we have some postpartum mood disorders. Postpartum. So we have the postpartum blues. It's a transient period characterized by mild depression, mood instability, anxiety, low concentration, increased concern over own health and health of the baby. So 50 to 80% of the mothers have this, and it happens or starts, let's say, 2 to 4 days postpartum. Lasts up to 2 days, but it can go up to 10 days sometimes. So usually up to 2 days, but sometimes it can go up to 10 days. It's related to purpurium. It's the period beginning immediately after birth of a child and extends for about 6 weeks. And it doesn't really require any psychotropic medication. But the patient is at risk of developing a postpartum depression. Now, there is postpartum psychosis, a very interesting case here, 1 to 2 per 1,000 childbirths, and it has an affective basis, so usually manic. It can be depressive and have suicidal and infanticidal ideations. 2 to 3 weeks postpartum is the onset, and can go up to 8 weeks. So we're talking about a couple of months here. And you usually give antidepressants, mood stabilizers, and antipsychotics in this case. Now, we have also postpartum depression. We mentioned it before. It's a major depressive episode which starts 4 weeks postpartum, so a month postpartum starts. 10% of mothers have this, lasts up to 6 months, and we must. This is a very important point here, is that we must ask for suicidal and or infanticidal ideation. It's very, very common that the mother has a suicidal ideation, so to kill herself, or sometimes to actually kill the baby. We can read here there are several risk factors like stressful lifestyle and conflict with the husband, lack of family support. All those factors increase the risk. Now, when the mother is breastfeeding, she doesn't really want to take medicine. We might give SSRIs, like we can see here, short term to the infant who is breastfeeding. We might do the ECT, like we said before. But the treatment with the SSRIs improves the outcome, the child outcome, in like a year or two. The impact on the child development, and this is what is important from the pediatric point of view, is that it creates insecure attachments at 18 months, and the behavior is highly disturbed at 5 years. There's a cognitive delay, especially in males, and there's an impaired mother-to-child communication. So now this concludes our depression. Well, I don't want to say depressive part of the presentation. I hope it wasn't depressive for you guys, but it concludes the depression part of the presentation, and we're moving on to the bipolar disorder. Another famous disorder, like we talked in schizophrenia. All those disorders are very famous in the literature, also in the popular lifestyle, in movies, and films and books and stuff like that. They usually refer to people, oh, suffers from bipolar, he's bipolar, are you bipolar, So we actually divide bipolar into type 1 and type 2. So in type 1, we have at least one manic or mixed episode, with one or more major depressive episodes, but they're not required for diagnosis. Now in number two, we have at least one major depressive episode and one hypomanic episode, and it's less intense than mania. There is rapid cycling, so at least 4 episodes with the MD, manic, mixed, hypomanic in 1 year. And there's a cyclosthemic, which is chronic and less severe. We have hypomania and moderate depression that alternate for at least 2 years, and they last for at least 2 months with symptoms. So to make it simpler here, bipolar disorder, when someone says, are you bipolar, they're usually referring to type 1. So you have at least one manic and one mixed episode, sometimes accompanied by one or more MDs, but they're not required for the diagnosis. Then you have type 2, the cycling, and the cyclosthemic. So a few words about the epidemiology of bipolar disorder. So 1% for type 1 and 3% for type 2. 1:1 is male to female ratio, and the average age of onset is 20 years old. Okay, this is straightforward information for you guys. Nothing hard really. And if you have family history of bipolar disorder, that increases the risk for sure. Increasing age increases the risk, and up to 15% of those that suffer from bipolar disorder commit suicide. Now, how do we diagnose it? Dig fast. Remember the mnemonic and the classification, so it doesn't really change. Dig fast. If we give antidepressants, we might cause manic episodes. And again, the simple principle that applies to all the definitions and the diagnosis that we gave already. Don't forget to exclude in the differential diagnosis the bipolar or the manic episodes induced by substances, drugs, amphetamines, so on and so forth, and or GMCs, general medical conditions, maybe some tumor that can cause psychotic features, or bipolar or manic episodes, trauma, etc., etc. Again, no psychotic disorder here causes bipolar episodes. Now, differential diagnosis obviously is cyclothymia or psychotic disorder, or the stuff that I just mentioned, the GMC and the substances, or delirium. How we treat it? Bipolar disorder is an emergency because there is an impaired judgment and there is a high risk of harm to self and others. So we must use antipsychotic drugs and give mood stabilizers, and we will talk about those on the next slide. We can use benzodiazepines for refractory agitation. As far as bipolar depression, we give antidepressants with mood stabilizers. We start with the mood stabilizers first to avoid the mania, which is very, very dangerous for the person and the others disease, and then we continue with antidepressants to treat the depression part of the spectrum, end of the spectrum. We can use ECT, and we can combine sometimes people that have depression, major depression, and the mania and the bipolar type 2. We can combine antidepressants with lithium also at a low dose. So lithium that I just mentioned. So we don't really know how it works. They say that when we take it, it goes into the CNS, interacts with neurotransmitters and receptors, decreases the norepinephrine release, and increases the serotonin synthesis. It might cause thirst, polyuria, diabetes, nausea and vomiting, weight gain. It has so many different side effects, lithium. And what we should remember here is the toxicity. So in concentrations higher than 1.5 millimoles per liter, it becomes toxic. So it causes ataxia, dysarthria, delirium, acute renal failure, and people that have a poor kidney function, people with like a dialysis machine, stuff like that, we don't want to use. We must not use lithium. We might use anti-epileptics, which raise the seizure threshold and decrease the synaptic transmission, or let's say block the synaptic transmission. We can use the carbamazepine, which is the second line, causing obviously some side effects, or we can use valproic acid, again causing several side effects that you guys can actually read on this slide. This is not very important in this aspect, meaning that we will go over those drugs in the chapter of epilepsy in neurology anyway, but it's good to know that we can use those drugs to treat we can use them as mood stabilizers in order to treat the bipolar disorder. Now, they might also block the serotonin receptors and potentiate the dopamine activity. So we have the lamotrigine, again, several side effects. And a very important side effect of lamotrigine is the Stevens-Johnson syndrome here, which is a form of a toxic epidermal necrolysis. It's a skin condition, life-threatening, where we have cell death, and the epidermis is basically separated from the dermis. Now, we talked about mood disorders, we talked about depression, we talked about bipolar, and we always mention that in the diagnosis or the definition of every disorder, never include as a part of diagnosis or as a part of the definition of those disorder, mood disorders that are caused by medical substances, right? So or other conditions, or GMCs in this case. So we're talking about hepatitis, encephalitis, pneumonia. Those are medical conditions that might cause or induce mood disorder symptoms. We can talk about endocrine problems, a problem with your thyroid, so hypothyroidism, or problem with the pituitary, hypopituitarism. There might be diseases such as polyarteritis nodosa, like collagen vascular diseases, vasculitis, inflammation of the vessels. We can have cancer in the pancreas. We can have cancer in the adrenal glands, pheochromocytoma in the adrenal medulla or medulla. We can have Huntington disease, personality disorders. All the drugs, antihypertensives, anti-Parkinsonian drugs, hormones, steroids, so on and so forth. All these factors are basically substances, drugs, or GMCs that induce mood disorders. So to wrap this up, we have the usual Q&A section. I'm sure it's your favorite. So, and it should be actually, because we have to actually go over the important topics when it comes to mood disorders, and by important I mean high yield USMLE topics. So let's start with question number 1. So which of the following terms has been used for bipolar disorder? So schizophrenia, paranoid schizophrenia, manic excessive disorder, or manic depression. So here, this is actually a trick question. So if you guys remember what the definition of bipolar is, right? So we usually have the ends of the spectrum. So we have the depression and the manic side, the manic episode. We actually looking for answer D, because it describes the two major characteristics. So the manic depression, the two major characteristics and opposite poles of the clinical spectrum of the bipolar disorder. So the mania and also depression. On to question number 2. This is a clinical vignette. We have a 35-year-old patient. His name is Tom. He's a bipolar patient, and he comes to the clinic for a checkup, for a follow-up exam, and obviously he has been taking drugs. His mood, well, the patient says that his mood has been stable with his current treatment plan, and for the past 3 months, he has had some hand tremors, so something like this. So, which of the following medications is the most likely cause of this patient's tremor? So, let's think. So we can look at the options here, and we can see that we have three drugs, and we have also a choice C, which says the patient is overreacting because none of these drugs is causing any of those side effects, so there's no medication. So take a few seconds and think about it. So what's up with Tom? So what causes Tom's hand tremor? So the correct answer here is D. We're talking about lithium carbonate here. Lithium carbonate is approved by the FDA for management of bipolar disorder, and is actually very common. So it's a lithium. It's basically lithium. That's what it is. And it's a common adverse effect of lithium carbonate. Now, we can see this on the fingers of the outstretched hand. So like this, we can see tremor like that. And basically, in order to decrease the tremor, what to do is we decrease the dose and decrease the caffeine also intake. Now, the other options don't make any sense really. Option A and B, those are anti-convulsants, meaning anti-epileptics. So carbamazepine doesn't really cause tremors, and the gabapentin might cause tremor, but we don't use gabapentin for treatment of bipolar disorder. So the right answer here is D. Moving on to question number 3. So you are in northern Sweden. Lucky you. You're in Umeå. Umeå is a town in northern Sweden. You are at the General University Hospital, and you are on call on a Saturday night. Don't worry, it will come. So Megan, she's a 26-year-old patient. She comes in. She says she feels very sad during the winter months, and also in September sometimes, and in the October. She feels down all the time during those months, and she had that for several years. She had that problem, and she's like, she comes to you and she's like, "Doctor, what I'm supposed to do? I don't know what to do." So, what's the problem here? And so, what is the mood disorder, and how do we treat it? Again, it's very good to diagnose the problem. Obviously, this is a major and very important part, but of equal importance is how you treat it, because you actually need to help the patient. So you guys are, while I'm just blabbering here, saying nonsense, you guys can actually take a look at the options, and this is actually a straightforward question if you study the material. So we're talking about seasonal affective disorder. We're talking about depressive episodes occurring during a specific time of the year. We're talking about the dark months, winter and autumn, and especially northern Sweden. In Umeå, Umeå is in northern Sweden, closer to the northern pole, so the North Pole. So there's not enough light. And what to do here? Well, you do light therapy, phototherapy, we also said before, and maybe antidepressants, SSRIs, if the condition is more severe. But you would start with the phototherapy. Now, moving on to question number 4, we have Ralph here. Ralph is 30 years old. He comes to Boston Medical Center, and let's take a pause here. Very nice medical center. I have actually worked there for several years. Very nice people, and good quality of healthcare. So that was a personal comment. So let's say so Ralph is coming at the BMC. And he's suffering from bipolar disorder, single manic episode. Which of the following behaviors would you as a doctor expect to assess? So we have here anxiety, that's the first option here, somatic complaints and insomnia. So that would be, let's say, choice A. We have B for elation, hyperactivity, and impaired judgment. We have C for apathy and poverty of ideas, and D, social isolation and delusions. So Ralph is coming. He's 30 years old, coming to BMC. He's a bipolar patient with a single manic episode. And what are we expected as doctors to assess on this patient? So again, while I'm talking, you guys can think about that. You don't have much time on the exam, so we shouldn't waste time here either. So the right answer is B. We're talking about a patient with a manic episode, so he would actually demonstrate flight of ideas and hyperactivity. So if we look back, we're talking about elation, hyperactivity, and impaired judgment. So elation is exhilaration, great happiness, and he feels he's invincible, so his judgment is impaired. Now, C and D don't really make much sense here because we're talking about symptoms in a guy with schizophrenia, so they don't really fit. And then A could work, but with a patient with anxiety disorder. Although a manic individual may also not sleep because of excessive energy. But the correct answer here is B. Moving on to question 5, we're talking about CBT. Cognitive behavioral therapy. And which treatment would be appropriate for a client with depression? So using the CBT. So we can do the negative thinking, we can analyze dreams, prescribe medication, or use the light therapy. So without wasting any time, this is another straightforward question. We're talking about CBT. We challenge a client's or patient's negative cognition. The belief is that the negative thoughts influence the feelings and the behaviors. We went over that during the presentation. It shouldn't be a problem for you guys. B, C, and D don't make much sense. Dream analysis is a psychoanalytic psychotherapy. Medication obviously would be pharmacotherapy, and light therapy would be for the seasonal affective disorder. So clear answer here is A, and that shouldn't be a hard or a tough question for you guys. Then we go into question number 6. So here we have Irene. Irene is 31 years old. She's depressed. She has major depression. She comes to the office. She has been taking antidepressant medication. Nothing has worked. We said before in the presentation that the last resort when it comes to the drugs is a monoamine acid. The MAOAs, the oxidase inhibitors, and monoamine oxidase inhibitors. She starts the medication. She comes back after several days and she says, "Doc, I have headache, I have fever, my neck is stiff, I want to throw up. What's going on?" And the night before, she went to the family feast and she ate. And the question here is that which of the following foods that Irene consumed during the feast might be responsible for the symptoms that she's describing? So is it cottage cheese? Is it beer and wine, bananas, or figs? Very interesting choices here by the writer. Very interesting choices of food. Makes me hungry. Both A and B are correct, and neither A nor B are correct. So again, something we went over in the lecture. So we're talking about B here. We're talking about figs and bananas and beer and wine. So all those are products that cause this symptom. So what happens here? So we talked about the monoamine oxidase inhibitors. They inhibit the monoamine oxidase, which breaks down all the neurotransmitters that we mentioned before: serotonin, dopamine, norepinephrine, and tyramine. So if a person takes this drug, then their oxidase will be inhibited. So less breakdown leaves more of those neurotransmitters available in the brain, which leads to an improved mood. The breakdown of tyramine is also decreased when those drugs are taken. So if you have too much tyramine in your body, it can lead to a hypertensive crisis. So within a few hours, you can get the headache, the stiff neck, you can have a change in the heart rate, you can have nausea and vomiting, you can have fever. So you avoid all the foods that contain tyramine. We're talking about cheese, wine, beer, bananas, figs. The only exception is the cottage cheese. The cottage cheese is actually an exception, and the cream cheese. Everything else is off limits. So, what to do? Well, you avoid coffee, you avoid chocolate, you avoid fava beans, and you also avoid sedatives, stimulants. Well, basically, you try to avoid everything. It's a very unfortunate situation. So, because they have so many interactions and so many side effects, those drugs, the monoamine oxidase inhibitors, they are prescribed after all the other antidepressants have failed, right? So this is the last resort, So remember, cottage cheese and cream cheese, the only alternatives here. Everything else is basically forbidden. Question number 7. You have a patient, bipolar again. This is our topic today. A lot of bipolar disorder patients. He has been taking D-valproex, which is the Depakote, and as a physician, you know that the patient should have which of the following tests completed before the initiation of the drug therapy. Should he check his liver function, thyroid levels, cardiac enzymes, or should he do a cell blood count? Now, take a few seconds, and we will also remember we're talking about a drug here. So the correct answer is A. Actually, we should do liver function tests and a complete blood count with platelets before starting therapy. And patients with known liver disease should not be given D-valproex sodium or Depakote, like we said here, right? There is a warning for hepatotoxicity, thrombocytopenia, and agranulocytosis. Thyroid levels, cardiac enzymes don't have to be performed routinely before starting this medication. So if we're looking at the big picture here, the liver function test is basically the most important test that someone can do, or must do actually, when they are prescribed the Depakote. Don't forget that Depakote is an anti-epileptic. Question number 8. Again, another patient, bipolar disorder patient, has been taking lithium, and he came to the hospital and he has dry mouth, nausea, vomiting, blurry vision, so on and so forth. So what do you suspect? What's going on with this patient? So you guys can read the alternatives here, and you can take a moment, you can take a second and think about what's wrong in this case. So we actually proceed to the answer, and the answer is D. The correct answer is D. Side effects associated with the lithium toxicity is diarrhea, dry mouth, nausea and vomiting, ataxia, slurry speech, tinnitus, blurry vision, muscle rigidity, muscle tone. All those are increased. So that's another straightforward pharmacology question. You guys are going to go over this again in neurology and also in pharmacology, the pharmacology part of your USMLE exam. It's a high yield question, and you guys should know the side effects of the lithium toxicity. Question number 9. Which of the following substances increases serum lithium levels? Excuse me. Which of the following substances increases serum lithium levels? Well, I'm not going to read them for you. You guys can actually read them. And you actually have to be really fast here. There's a lot of names from choices A to D, and they're very similar to each other. So you have to have a fast eye, let's say, a quick eye here, and come up with the right answer, which is C. Furosemide, it's a diuretic. Alcohol and fluoxetine. Fluoxetine, we said it's a antidepressant, increase serum lithium levels. Alloperidol increases the neurotoxicity despite normal serum levels. And the NSAIDs, the non-steroidal anti-inflammatory drugs, the NSAIDs, like ibuprofen, decrease the renal clearance of lithium. So ibuprofen increases the serum lithium levels by 30% to 50% in 3 to 10 days. That's actually a very interesting piece of information here you guys should pay attention to. So correct answer would be C here. We're talking about furosemide, alcohol, and fluoxetine. So those actually increase the serum lithium levels. The last question would be, what is the difference between bipolar 1 and bipolar 2? And that's another high yield question, or topic in the USMLE exam. So what is the difference between those two? Is it that the bipolar 1 has many hypomanic episodes? Is it that one is more disruptive than type 2? Is it that type 1 affects women only or more? Or is it type 1 involves changed moods of anger and paranoia? So the correct answer here is B. You guys can actually take a look at this one more time. So type 1 is more severe. The symptoms create more disruption in functioning than type 2. We actually mentioned this during the lecture. So we have in type 1, we have several manic or mixed episodes. The person is basically alternating between moods, and he's going from major depressive episodes to manic episodes, and so on and so forth. So type 1, remember, if someone asks you what type of bipolar disorder is more severe, type 1 or type 2, type 1 is the correct answer. Type 1 is more severe, and it causes a very high level of disruption in functioning of the individual. So this concludes our lecture on mood disorders. I hope you guys liked it, and I'm sure you guys learned a lot from this lecture. Again, I will repeat one more time that this is a very high yield topic, as well as the psychotic disorders that we have on another lecture. And I hope I'll see you guys next time.